Hi everyone, I think we'll probably start the webinar now. We'd like to thank you all for attending the fifth webinar in the series. We'll begin with an acknowledgement of country. We would like to respectfully acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the land on which the College is located. We acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. We pay our respects to their elders, both past and present. In recognition that we are a binational college, we take this opportunity to acknowledge Maori as Tangata Whanau and Treaty of Waitangi partners in Aotearoa, New Zealand. Together, we restate our shared commitment to advancing Aboriginal, Torres Strait Islander and Maori health and education. So, thank you for attending the fifth webinar in the series, Additional Findings in the NLCSP. We have two fantastic speakers ready for you. Presentations will be made by Dr. Mark McCusker and Dr. Diane Pascoe. We will have 15 minutes at the end of the presentation for any questions, so if you would mind waiting until the end, we will get to as many of you as we can. All presentations will be recorded and made available via the College NLCSP webpage over the next few days. We ask that you ensure that your microphones are muted and cameras are off during the presentation. And now we'll just introduce our speakers. So Dr. Mark McCusker is the Acting Deputy Director of the Department of Medical Imaging at the Royal Melbourne Hospital and an Honorary Lecturer at the University of Melbourne. Mark is a thoracic radiologist with interests in thoracic oncology, interstitial lung disease and cardiac imaging, and is a founding member of the Victorian Society of Thoracic Imaging. He is an investigator on the International Lung Cancer Screening Trial, and he has been heavily involved in the development and delivery of the radiology components of the National Lung Cancer Screening Programme as a member of the steering committee for the ANSTER Lung Cancer Screening Working Group and the co-chair of the Incidental Findings Subcommittee. Dr. Diane Pascoe is a thoracic radiologist with over 12 years of experience in diagnostic and interventional thoracic radiology. She is the Acting Director of Medical Imaging at Royal Melbourne Hospital, a founding member of the Victorian Society of Thoracic Imaging, and an honorary lecturer at Melbourne University. An investigator in the International Lung Screen Trial, Diane has also published and presented on topics including lung cancer imaging, pulmonary nodule detection, AI in radiology, and imaging of pulmonary venous thromboembolism. Since 2019, she has been more focused on improving care, having worked with Cancer Australia to update the lung cancer optimal care pathway, provided radiological advice to the Cancer Australia Lung Cancer Screening Inquiry, and now as a member of several committees and working groups to help develop and deliver the Australian National Lung Cancer Screening Programme. And with that, I will hand over to Diane. Okay.
Thanks so much. Super kind words there, Liam. And I'd just like to thank everybody for joining this evening to be involved in this conversation about the incidental or additional findings in the National Lung Cancer Screening Program in Australia. I'd like to add my acknowledgement of the country that Mark and I are both coming to from today, the Wurundjeri people of the Kulin Nation, and pay respects to elders past and present. So this evening we're going to try and look at the approach to assembling the Australian NLCSP additional finding guidelines, give a bit of an overview of the guidelines and how we got there, and focus our discussion on some of the selected additional findings of interest. This is the QR code and the link for the additional findings guidelines, which have been published on the college website. Don't worry if you don't grab it now. Mark is also putting up the QR code at the end of his part of the presentation, so you won't miss out. So we face a unique challenge in lung cancer screening, which is a really exciting program. It's the first, as I'm sure you've heard, the first new cancer screening program in Australia in over 20 years, and it's a radiological screening program. But it's going to provide us all some challenges compared to the existing screening programs out there. Bowel cancer screening, it's pretty binary. There's either fecal occult blood or there's not. Cervical cancer screening, a little more complex. You've got three options here: high risk, low risk, or negative on the high vaginal swab. We start getting even more complex with our other radiological screening program at BreastScreen. You either have a clear or a recall, but we're starting to get the flavour of some additional findings here. Most recalls are for breast parenchymal disease, but you do occasionally get an additional finding or an incidental finding with an axillary abnormality or a skin abnormality. But this is what we're going to face with lung cancer screening. So not only we're going to have to deal with all of the issues related to the diagnosis of the nodule and the cancer itself, so the nodule size, number, morphology, looking at location, growth and change, the background parenchyma, emphysema is an important part of the Brock calculator, the presence or absence of lymph nodes and pleural thickening or effusion, all of those put together to make our assessment of whether or not we think this person is or participant is at increased risk of lung cancer. We also have to look at all of the other organs outside of the lung parenchyma as well. So we're going to look at kidneys and liver and spleen, the gastroesophageal junction. We're going to see plenty of thyroid glands, and in every participant, we're going to image some bones. And so while we're doing targeted screening for lung cancer, we're also accidentally performing non-targeted screening of a whole lot of other organs for a whole lot of other pathologies. And one of the challenges for us will be to try and handle those, manage those, and hopefully limit those. One of the ways we can limit the number of additional findings we see outside of the chest is to limit the scan length to just the lungs. So I just remind you that there is a chest CT acquisition guideline available also on the college website that helps you get your practices prepared. And I just stress the importance of educating your radiographer group to really limit down the scan length. It has a double win. You decrease the dose to your patients or the participants, and we also decrease the inclusion of other organs and tissues that we then need to assess for abnormality. Every radiologist in this room understands the challenge of incidental findings. We deal with them every day. There's plenty of research and commentary out there talking about, victims of medical imaging technology or vomits, cascades of low-level care. These are all the things that we have to deal with every day in our practice, and they're really just further enhanced or highlighted in the screening population, because not only here are we going to find all these additional or incidental findings, but we're finding them in a well population. These people are going to walk in largely asymptomatic, and many of them without known health conditions. So we're not targeting a known clinical symptom. The benefit in this setting, in this screening population, is that we know that we've got an enriched population. So we're screening a high-risk group of smokers or recent ex-smokers. And we know that they're going to be at increased risk of many smoking-related conditions such as cardiovascular disease, emphysema and osteoporosis. And many of these, particularly if they're found at an early stage, there are interventions and treatments that can help minimise the impact of those diseases on both their health span and their lifespan. The downside is we know there are harms that we can possibly create for these participants. So over-investigation and over-diagnosis are well understood. There will be costs to the participant and to the healthcare system, both of which are important. And I just remind everyone here that the CT itself is mandated to be Medicare rebate covered, but none of the other ancillary appointments or scans that we will create a cascade of will be covered by necessarily covered by Medicare. So there can be out-of-pocket expenses that could be significant to the participant. We've also got to think about intangible costs, so time away from work, time away from caring responsibilities, and associated travel, particularly in rural and remote areas. It can be hard for people to access appointments, particularly in those rural and remote areas. And we mustn't forget about this associated anxiety that this entire population of people are going to have about coming for their scan in the first place, the associated stigma. If we add a whole lot of burden for low risk findings, we do run the risk of losing these participants to screening. So how common are incidental findings in lung cancer screening cohorts? You'll probably have seen that there are reported rates between 8 and 94%. Hugely valuable and helpful data there. But if you narrow it down, you use the ACR data with the significant finding modifier, the S modifier, it's about 20%. And in our own international lung screen trial in Australia, which looked at over 4,000 participants in Australia and Canada, we found that about 73% of participants had at least one incidental finding, and similar to the ACR data, about 21% had an actionable finding as defined by those findings being reported in the conclusion. So we as radiologists have a key role in limiting these cascades of low value care. but we need to have robust guidelines behind us to be able to do so safely. Just as a little side note, you may be wondering why the term additional versus incidental. It's something that we talked about amongst ourselves and also with colleagues from different craft groups, particularly the Thoracic Society of Australia and New Zealand. There is a subtle difference in meaning and interpretation between the two terms. The use of the word incidental often implies a lack of importance, and it's often a finding that's unrelated or unexpected in a scan. Whereas in our screening population, we're looking at an enriched population, and this term additional recognises the potential significance of these findings in an enriched population. So these findings may be related to their smoking history, and they may be expected. You know, we know that 50 to 60% of participants are going to have emphysema or coronary artery disease. And I just point out at this juncture, for those of you who aren't aware, that more participants died in the National Lung Screen trial of cardiovascular disease than of lung cancer. So these are important findings for us to identify and report appropriately. So the aim of the guideline is to include findings that are common and that are known to correlate with symptoms or disease, and for which an intervention is available. So these are what we term actionable findings. These are something we can do something about. And we also similarly want to avoid reporting those findings which are known not to correlate with symptoms, that require or have no intervention. And we really encourage those not to be documented, so we have clear and unambiguous communication with the referrers about what they should be doing with these findings that are reported. It's not to say that we're going to ignore those. They still need to be looked at by radiologists in future, and we need to be thinking about those additional findings at every time we review the scans, and if there are changes that make them significant, reporting them at that stage. Important exclusions from the guidelines. So we can't include every single abnormality in the guidelines. It's just not feasible. So rare findings have been excluded, and we've also excluded findings that are reportable to government or that warrant urgent clinical management. So these we would suggest every radiologist would manage as per their usual routine practice and communicate to the referrer in the appropriate channels. A bit of background now on how we came to approach the development of the guidelines. So we developed a subcommittee of the ANSTA lung cancer screening group, and 15 fantastic people worked with Mark and I on developing these guidelines. We started with the existing comprehensive guidelines that are out there already. We looked at those and thought about those carefully in the context of our Australian lung cancer screening population, what were different about our people to theirs, particularly the screening interval. So the ACR, for example, use an annual screening. We're using a biennial screen or even a second year screen. And we also thought about the Australian resources, you know, the availability of scans and appointments in particularly rural and remote settings. We then used other guidelines or evidence to add into those and simplify or pare back those guidelines wherever possible, or to add in extra value where we saw there was some. So we started with our incidental findings subcommittee, created a draft. It went up through the project steering committee. Once everyone was happy with it, it actually went out for 2 rounds of consultation, firstly through the University of Melbourne and then through our college. And there was a large range of bodies that were offered the opportunity to comment. All those comments were collated, taken back through the steering committee and the incidental findings subcommittee, and voila, we created the guideline that you will now see on the website that's been endorsed by the Department of Health and Cancer Australia. So the 2 main goals of the guidelines, really to sum it up, are to discourage the reporting of insignificant findings and to draw our attention to reporting and giving recommendations about findings that are not commonly reported or a bit challenging in deciding what the recommendation to the referrer should be. So a couple of examples here, some of the sort of more straightforward ones: thyroid nodule, If you see a thyroid nodule that's more than 15 millimetres or has some suspicious clinical features or imaging features, we encourage you to report that. And we'd like the wording in the report to be verbatim what is in the guidelines. It makes it really easy and clear for upload into the National Cancer Screening Register. The recommendation associated with that will go in the conclusion of the report is that this is for clinical review and refer for thyroid ultrasound. If you don't see those features, don't report it. With the liver lesions, if you see a nodule less than 1 centimetre, so small, doesn't matter if it's cystic or solid, do not report it. If it's a simple cyst, which is a homogeneous and well-defined lesion with a less than or equal to 20 Hounsfield unit density, do not report it. If it's a lesion that's greater than 1 centimetre and it's not a simple cyst, we encourage everyone to report those and use the terminology refer for liver ultrasound in the conclusion of the report. So that sums up my part. I'll now hand over to Mark to take you through some more specific details on some samples.
Thanks very much, Di. Can you see my screen okay there? Yeah. Okay, so I am going to look specifically at these 3 findings. As Di says, these are not commonly reported by radiologists, but the guidelines do recommend identification and reporting for screening participants, and we'll look at why that is the case. So firstly, calcified coronary artery atherosclerotic plaque. Sometimes this is referred to as coronary artery calcification, but I prefer the more specific term, including atherosclerotic plaque, as this is the visible abnormality on CT represents the disease itself. It's the actual manifestation of coronary artery disease, which is an important finding. Why is it significant? Well, the presence of calcified coronary artery plaque is a risk factor for poor outcomes, which include cardiovascular events, cardiovascular mortality, and mortality from all causes. Increasing plaque burden is associated with higher risk of all of these things, and traditionally the finding is underreported by radiologists. In lung cancer screening cohorts, it's very common, with a prevalence of over 50% in numerous reports. And remember, as Di said, it is the leading cause of death in lung cancer screening cohorts. It exceeds the death rate from lung cancer. And also in lung cancer trials, the finding is, again, frequently underreported by radiologists. So most radiologists will be at least somewhat familiar with the most common method for quantifying calcified plaque, which is the formal calcium or Agatston score. This employs ECG gating, strict CT acquisition parameters to obtain images, and specialized software, which then segments the plaque and calculates the score based on total plaque volume and density. But there is another method. It's a simple visual scoring system, quick to perform, which can be used for non-gated CTs, such as those we'll be reporting in the screening program. For small isolated flecks of calcification, you assign a grade of mild. For continuous thick deposits, a grade of severe, and then for findings in between those, a grade of moderate. So here's another example. Isolated flecks of calcification on the far left image, I get a grade of mild. Thick continuous deposits in the far right image, a grade of severe, and then moderate for appearances in between mild and severe. Now, formal calcium score is a very reliable estimator of risk of myocardial infarction, death from coronary artery disease, and all-cause mortality. But the simple visual assessment has a high degree of agreement with the formal Agatston score and a strong association with cardiovascular outcomes, despite the fact that it is quite simple and quite easy to perform. So the recommendation in the guidelines is shown here. We are recommending that radiologists report coronary artery calcified plaque when it's present and assign a simple visual grade of mild, moderate, or severe. The management recommendations, which we ask you to, again, state verbatim in your reports, would be for mild calcified plaque, clinical review and consideration of lifestyle modification and pharmacological therapy. And for moderate or severe grades, a slightly stronger recommendation we basically just remove the instructions to consider and state that lifestyle modification or pharmacological therapy should be initiated. So next we have aortic valve calcification. Why is this significant? Well, calcification can be the result of numerous pathologies of the aortic valve and is the driver of aortic sclerosis and aortic stenosis. So just like calcified plaque in the coronaries, when you see aortic valve calcification, you're seeing a manifestation of pathology of the aortic valve. Severe calcification is related to the presence and severity of aortic stenosis, as well as an increased risk of cardiovascular events and mortality. Risk factors include advancing age, smoking, and hypertension, so it's not surprising that this finding is quite common in lung cancer screening participants. And like calcified plaque in the coronaries, it is also underreported by radiologists. It can be formally quantified in a similar way to coronary artery calcified plaque using segmentation software, but there's also a simple visual scoring method, which is easy and fast and can be applied to non-gated studies. A grade of mild is given to small punctate isolated foci of calcification, moderate to larger foci, and severe when all three valve leaflets are affected. Here are some more examples. In the top row, if you can compare the appearance on a non-contrast, non-gated CT to axial slices from a gated post-contrast CT in the middle row, and then on-fast reconstructions, reformats of the aortic valve in the bottom row. Again, the grading system, mild with small flecks of calcification, moderate with more numerous foci, and then severe when all three valve leaflets are affected. Now, it can sometimes be challenging on a non-contrast study to figure out where the aortic valve is. So one trick is to review the coronal reformat and remember that the aortic valve in the majority of people with structurally normal hearts is situated obliquely. So the inferior extent is it's towards the right, and the superior extent towards the left of the left ventricular outflow tract. You can see that quite clearly on this post-contrast study over on the left side here, this post-contrast study of a normal valve, and then use that image in your mind to identify where you need to look for calcification on this non-gated, non-contrast study on the other side. When you encounter the valve in the axial plane, the most inferior leaflet, so in the red boxes and identified at the level of the red line, is situated, that most inferior leaflet is situated to the right side of the aortic root. And as you scroll superiorly, so through the yellow and then through the blue levels, the position of the leaflets move from the right side to the left side of the aortic root. And that pattern is obviously reproduced on non-contrast studies, allowing you to identify the inferior leaflet towards the left in the red box, and the more superior leaflets towards the right in the blue, the inferior leaflet towards the right and the superior leaflet towards the left in the blue box up here. In terms of prognostic implications, the formal calcium score correlates strongly with the severity of aortic stenosis on echo. But the simple visual score has excellent agreement with the formal scoring. And moderate and severe grades using the simple score have high sensitivity and high specificity for aortic stenosis on echo. So the guidelines recommend assessment of the aortic valve in all screening participants, reporting moderate or severe aortic valve calcification, but not reporting mild, and recommending echocardiography in those moderate or severe cases. And finally, then, interstitial lung abnormalities. What is an interstitial lung abnormality? It's a recently recognized or described entity with a specific definition. Firstly, the presence of one or more of the following abnormalities in a non-dependent distribution, so around the lateral side or the anterior lungs if the patient is lying on their back. And those abnormalities are ground glass opacity, reticulation, architectural distortion, traction bronchiectasis, and honeycombing. Secondly, they must be incidentally detected. So the definition does not apply if you know that there is already a history of interstitial lung disease present for that participant. And thirdly, they need to involve at least 5% of any lung zone. So what is a lung zone? There are 3 on each side, upper, middle, and lower, with borders defined by 2 axial planes, the more superior through the inferior aspect of the aortic arch, and the lower plane through the level of the right inferior pulmonary vein. Those 2 planes define the boundaries between upper and middle and lower for each side. And what is 5% of a lung zone? Not very much is the simple answer. You can see here the regions of abnormality have been contoured and measured with volumetry software. The top image highlights almost 3% of a lung zone, the middle almost 7%, and the bottom just over 10%. So clearly 5% of a lung zone lies between the top and the middle image, which is not a lot. So the volume of affected lung does not need to be very large for this 5% requirement to be satisfied. No one is going to expect the reporting radiologist to actually try to measure this volume. This is more just to get your eye in to the fact that 5% is not a large volume of lung parenchyma. This is another example of an interstitial lung abnormality. There are lines in the subpleural lung, so reticulation is present. There's also patchy ground glass opacity, probably a few small patches of architectural distortion down in the extreme costophrenic angles. It involves anterior and lateral lung, so it is therefore a non-dependent abnormality. And if we compare to remember our image of 6.7% of a lung zone, it's clearly more than that. Therefore, it satisfies the definition requirement of being more than 5% of a lung zone. Now, an important question that's often raised when discussing interstitial lung abnormalities is what is the difference between these and interstitial lung diseases? Well, an ILA is purely a CT diagnosis. If the relevant findings are present and incidental, of course, you can report an ILA. An ILD, on the other hand, is a multidisciplinary team diagnosis. So the appropriate CT findings are required, but also the appropriate history, including relevant exposures, family history, etc., clinical examination, and then relevant tests like pulmonary function studies and autoimmune blood screens, etc. What this means is an ILA might represent an ILD in the appropriate clinical context. Now, when you're reporting in the lung cancer screening program, it's very unlikely that you will be provided with enough clinical information to be able to make a determination whether something represents an ILD. So for that reason, we've just called this item ILAs, because in the context of your screening reports, these will most likely all be technically incidental. Why are we interested in detecting these? Because some will progress up to 20% in 2 years or 48% in 5 years by some reports will progress to fibrotic interstitial lung disease. They're associated with increased mortality and with increased risk of complications during treatment for lung cancer. Smokers are at a higher risk, so rates will be higher in lung cancer screening cohorts. And just like the other findings we've looked at, these are also underreported on CT. This is an example of an ILA progressing. You can start seeing the top left-hand corner. This is the scan of an individual who, with CT findings of an ILA, who is asymptomatic with normal FVC and normal diffusion. A biopsy at that time demonstrated a UIP pattern on histology. 2 years later, you can see that the lung abnormality has progressed. There is now evidence of traction bronchiectasis, which is a marker of fibrosis. Diffusion capacity has reduced, but the FVC is still normal. Then after 7 years, there's now clear fibrosis with honeycombing. FVC and diffusion are markedly reduced, and the participant now has symptoms. So this progression in some circumstances, this does not happen to all people with ILAs, but some will undergo this progression. Unfortunately, it can't be prevented, but there are medical treatments available which can slow the progression of fibrosis. So the idea is to identify this sort of case early, at an early stage, and implement treatment before symptoms and irreversible fibrosis develop. So as I said, not all ILAs will progress. There are some imaging features which are associated with a higher risk of progression. So firstly, a non-subpleural distribution of ILA. So for example, here where there is evidence of subpleural sparing in the right lower lobe, this appearance is usually not progressive. Subpleural non-fibrotic abnormalities are a bit more significant, but the highest risk group for progression are those with subpleural fibrotic abnormalities. So you can see in case number 3 here, traction bronchiectasis, maybe a little small patch of honeycombing over on the left. So based on all of that, the following item is included in the guidelines. Radiologists are asked to report ILAs with high-risk features, which are reticulation, honeycombing, traction bronchiectasis, and progression. And for ILAs with these high-risk features, the recommendation is for clinical review, high-resolution CT chest, and respiratory medicine referral. We're also asking radiologists to identify ILAs without high-risk features, and those would be pure ground glass opacity or stable findings. And for those cases, the recommendation remains clinical review, but not referral or further imaging. Instead, we just ask you to make the comment that these findings will be assessed at the next screening CT, which will obviously be 2 years or earlier. One final thing to consider is what happens when participants leave the screening program. Screening stops for participants who are 71 years or older. The additional findings guidelines assume ongoing participation in the program. So that means that they are designed for participants who will be receiving CT scans once every 2 years. And the recommendations rely on that fact that another scan will be happening in 2 years or earlier. Once the participant has their final screening scan, radiologists need to keep that in mind, that they will no longer be receiving biennial CTs, and so they should tailor their recommendation and apply their best judgment when making recommendations for additional findings under those circumstances. So, for example, an abdominal aortic aneurysm of 41 millimeters is not recommended for reporting by the guidelines, but it will be up to the judgment of the reporting radiologist whether to make how to make a recommendation for this on the last program CT. So to summarize, we've looked at the National Lung Cancer Screening Program additional findings guidelines, how they are based on existing international guidelines, but tailored for the Australian screening context using multidisciplinary collaboration and consensus. We've looked at 2 important functions of the guidelines, which are to discourage the reporting of insignificant findings, and then to focus attention on findings which are not commonly reported, but have the opportunity to provide benefit. And those, as we saw, were coronary artery calcified atherosclerotic plaque, aortic valve calcification, and interstitial lung abnormalities. So these guidelines are the product of a very extensive collaboration. There are numerous individuals and organizations who made extremely important contributions, and Di and I would like to thank them for their very valuable input, particularly our fellow members of the ANSTA Additional Findings Subcommittee and the ANSTA Steering Committee. You can find the guidelines and other information related to the program on the RANSCA Cancer Screening Program webpage, and here are some additional recommended articles if you want to do a bit more reading on coronary artery calcified plaque, aortic valve calcification, and ILAs. Thank you very much. I'll put this back. Here you go.
Great. Thanks to Mark and Diane for a fantastic presentation. We'll open the floor to question and answers for maybe the next 15 or 20 minutes. We have a question from Xavier Yu. I'll read it out to you. Did I hear that correctly, that incidental findings we may find on a chest CT may not be eligible for a Medicare rebate for following imaging, example, breast mass? Is this any different for CT chests requested for different reasons outside the NLCSP?
It's not that it won't be eligible for a Medicare rebate, it's just that it's not mandated that there's a no gap fee. So you're not allowed to charge a gap for the primary screening CT, but any ancillary appointments or scans that are created from the screening CT are open to providers charging a gap fee. So that's the difference.
Great. If anyone else has any other questions, you can raise your hand or else unmute and ask away.
We must have explained everything just so brilliantly, Mark. No questions. Oh, there we go.
Okay, we have one from Anthony Felber. Anthony, do you want to go ahead?
Yeah, hi, thanks. Great presentation yet again. What's the average reporting time per scan? It seems this is, I mean, I report a lot of scans at work, but this is really, you've got to concentrate, get it right, make the recommendations. The average punter radiologist, what's the time per scan, do you think?
Yeah, I think that's quite a hard question to answer. That's obviously going to depend on the individual. It's going to depend on what software you have available or whether you don't. I suppose what we have done is tried to make this easier for radiologists, but through things like this guideline. So the structured reporting template, which will be available very soon, includes all this information and gives you suggestions, if you like, of how to incorporate all this stuff into your RIS in terms of macros, drop downs, etc. So to speed the process along. Yeah, there are a lot of things to identify. There's obviously all the work with the nodules and then the additional findings. But if you have a clever setup, for example, you might just click one box for your moderate coronary artery calcification and one box for your severe emphysema, and then you're done. You know, that's certainly how I intend to report within the program. So that the sort of structure that we're trying to impose on things, I think will help. But yes, you are absolutely correct that it will be, challenging work.
Okay, we have another question from Cecile. The workshops had mentioned reporting bone density at L1 being less than 100 HU. Is that to be included or not? Thank you.
I just answered that in the chat. Sorry. Yes,
Okay.
yes, it is included. We've only given a snapshot of a few examples this evening. There are much more extensive inclusions in the guidelines. So I definitely encourage you to have a look at the guidelines on one of the links that we provided, and Liam will make available at the end of the talk, or you can find just by searching on the college website. We cover pretty much every common finding in most regions.
Great, and we have another one. If severe coronary artery calcs, why not recommend specialist cardiology review?
That's a good question. It's not really necessary for severe. So severe in the simple visual score implies a severe burden of calcification. It's easy to get that confused with severe coronary artery stenosis, right, which probably has a potential for symptoms, coronary artery syndrome, etc. But severe in this context just means a lot of plaque. Now the risk of a coronary artery event is higher for those people, but it doesn't mean that they have one or are going to have one, if that makes sense. So severe calcification can be managed by referrers, and that will be appropriate in most cases. But will also serve as a prompt, if it's reported, for the referrers to ask the participant maybe a few more questions about chest pain, et cetera, to maybe elicit some symptoms of actual active ischemic heart disease. So yes, so it would be overkill to refer all of those people to a cardiac clinic, and that's not. With this, we have based our recommendation on some other international guidelines, and that's not a standard approach. But a subset of those people probably will need cardiology intervention, and it'll be up to the referrer to sort of tease out who those are.
Okay, great. Thanks, Mark. And Dr. Saleh Ayesa, who is the author of our online education modules, has also said that the online modules will expand on top of the guidelines, so they will answer a lot of your questions too.
And those online modules are extremely excellent, which Sally has put together, and they're beautiful slides and they're extremely well done. I was reviewing some of those today, so I would encourage everyone to look at those when they become available.
Yeah, they are super, and they've got examples of every finding, which is not something that we could cover in 15 minutes today. So we've really just focused on the big ticket items, but Sally's got examples of everything included in there.
Okay, I don't see any more questions. Okay, we have another one from Michael Ryan. I never thought as a radiologist I would be recommending management and treatment for coronary calcium findings. Would it not be more appropriate to simply imply correlation with vascular risk factor profile is advised?
Well, we have based our guidelines on international recommendations with input from cardiologists, as I've said. I think it's important to give if you have a high burden of coronary artery calcification, it's more than just you need your risk factors identified. It's you have significant risk just by virtue of the imaging appearance. So yes, I mean, where to draw the line on management and treatment? Some guidelines would suggest we should actually recommend a statin for a moderate calcification, and then maybe aspirin for severe. We haven't gone to that extreme. But these were developed with the College of GPs, with the cardiologists, and as I said, using guidelines. So we're comfortable with the language, and that's why we feel comfortable recommending it to be used by all of the radiologists reporting in the program.
Hey, great. Thank you, Mark. I think Amy Baker has her hand up, so go ahead, Amy.
Question related to
I can't really hear you, Amy. I'm sorry.
sorry, can you hear me now?
Yes, much
Yes.
better.
Right,
Thanks.
sorry about that. I had a question about reporting abnormalities that are already known about. So, for example, if someone has coronary artery calcification and they've had coronary artery bypass graft surgery, whether we just leave that completely blank. And similarly, if, say, we're reporting a follow-up study and the previous reporter has already commented, for example, that they've got severe aortic valve calcification, whether we repeat that or whether we just leave it completely blank to simplify the conclusion of the report.
Yeah, I think that's entirely up to you. We haven't gone into being very prescriptive about things like that, but you're right. If someone has had bypass or stents, then the presence of the plaque is sort of irrelevant at that point. People will approach this differently. I think that can just be up to the discretion of the radiologist what they think is more clinically appropriate. I don't know. What do you think about that, Di?
From a data extraction and wanting to do the research on this down the track point of view, I would rather everybody didn't report it because I want to know about it at incidence, at prevalence, not count it twice or 3 times or 4 times through the program. But I can understand people will feel uncomfortable not reporting, particularly if there's significant findings on subsequent scans. So, maybe the balance there is to include a comment in the special comments, but not use or in additional comments, but not use our particular terminology, and maybe not include it in the conclusion of the report in the specific NCSR, so the National Cancer Screening Register upload. In the language that would go into the register. Maybe that's the compromise that I would probably choose to take.
Okay, we have another question in the chat. We recommend biopsy for TIRADS nodules. Why not coronary CT?
I don't understand the question.
Robin, are you
that was
suggesting?
more to do with it. He was just answering to the question before.
Oh, excuse me. Okay.
Oh, okay.
We have a hand raised by Madav. If you want to go ahead, Madav.
Yeah, my question is, has any thought been given to what happens when a person in the program has a follow-up at another location? Will the images be available on a central PACS for everyone to be able to see in the future?
We would love that to be the case. We have been strong advocates right from the very beginning of the contemplation of the inception of this program that a vendor-neutral archival central imaging repository was a great idea. Unfortunately, at Go Live, there is no funding for that. We continue to advocate very strongly for it and believe that it would add huge value to the program. In the interval, we are using sort of some surrogate things to make it easier for radiologists to be able to find prior imaging. So one of the mandated fields in the National Cancer Screening Register upload will be the location, the date of the prior scans, so that radiology practices can go and find those scans and have them downloaded or available to review at the time of the most recent scan. But it does put the onus on us to go out and actively seek them at the moment. There's also in the educational material for GPs and participants, there's a lot of wording to encourage participants wherever possible to attend the same clinic. So we know that's not possible for everyone when they move and various bits and pieces, but if you're staying in the same area, there's strong recommendations to attend the same clinic.
Thanks.
Okay, we have a question from Dr. Chris Chan. What about downgrading a calcification finding on a follow-up CT?
Well, that's going to be unlikely. I think that the calcification is going to get better, but I don't know if this question is about if you disagree with the reported grade on the previous one. You know, if someone's reported severe and you think it's moderate, I think you can express that in your conclusion with the reasons why, if you like. I think it's going to be rare that happens. I mean, for those simple visual scores, the inter-observer variability is surprisingly good for things that are, you know, that they're very defined in this very sort of broad way. But the inter-observer variability is minimal between radiologists. But yeah, I don't know if I've answered that question fully. Okay, Chris, if you want to elaborate, we can go into that.
Okay, Chris.
To do with whether the management implications, because if you genuinely think it's improved, then your management in the protocol is like, well, you know, it doesn't need to be followed up.
Yeah, you're talking about coronary artery calcification. What kind of calcification are you talking about?
Coronary artery one, for instance, like.
Yeah, I mean, in my experience, it doesn't improve though. Yeah, doesn't really get better. And again, these are sort of gross, epidemiological risk factor things. You know what I mean? It's not the management for moderate and severe is actually the same. So it's a prompt to the GP to think about starting a statin plus or minus aspirin and maybe taking a detailed cardiac history. You know, so whether it changes between scans is unlikely, and it's not really going to make much of a difference.
Well, even if it possibly did downgrade, they've still got the disease. And so you're not going to stop treatment unless there's some reason to, whether they've aged out of treatment or they've got complications related to the treatment. You're going to continue to treat the disease, even if it looks like the disease is getting better because they got the disease. Yeah. Sam Ellis has asked a good question about participants that may see different GPs that are not aware of previous actionable additional findings and whether they were investigated. I guess that's the downside of my approach, Sam, would be that they won't be visible in the screening register for that particular scan, and if the GP is only looking at the last result, it won't be available in the screening register. It would be available on their report if you report it in my fashion, but not not with recommendations and things. So I don't know if we know the right answer on that. I think that's going to be a nuanced thing.
Okay, and Warwick Lee said, how is recruitment going and who is recruiting?
Do you mean recruitment of participants or recruitment of practices to participate in screening, Warwick? I'll answer both. So recruitment of participants hasn't started yet. So GPs are aware of this program starting, though having said that, we've had a couple of requests already come through the Royal Melbourne. I don't know if anybody else has that we've had to send back. But so there's no recruitment of participants yet. It starts on the 1st of July and the public advertising campaign will begin on the 1st of July, so we're expecting a slow ramp up. If you're talking about recruitment of practices, that's a trickier thing. I think most practices would now be aware of the up and coming screening program, and it's for each individual practice to make a decision about whether or not they want to participate, whether they have capacity, whether they see it as a financially viable option, whether they've got expertise within their group to be able to provide the service.
Okay, I think we have another one. Who will upload the non-clinical data to the system?
Are you meaning the non-report data? So things like when the scan was performed and where it was performed and those sorts of things? They will be, yeah, they will be required by the radiology practices to go as part of the upload to the National Cancer Screening Register. There'll be information coming out about how practices can prepare and get ready for doing that. If it's not already available online, I'm not sure, Liam, if that's available, but I think the practice preparedness document's up on the college website, isn't it?
It is, yeah, it should be, yes. Miranda Timinovich has said the structured clinical radiology report includes a field for actionable additional findings, yes, no. This can be filled as no for data purposes and all descriptions still given in the description fields. Recommendations can still be given in the conclusion. Then we also have a question, will scanning only to be done on the lung kernels or will soft tissue kernels also be required? Can we keep scanning to lung kernel and lung window only? This would minimize the requirement for incidental findings and keep imaging in this setting appropriate to lung cancer screening.
Yeah, so I mean, we have the technical guidelines are available on the college website. I think it is, we are imaging the chest and the data is there. So I think we probably will need to do, it's obviously only one scan, right? But I think reconstructions of the mediastinum and soft tissues and then the lungs should be performed. Yeah. It would be nice to have all those things subtracted out, so we don't have to look at them. But unfortunately, I think that the data's there, and we will have to look at it, and therefore we need the appropriate windowing and reconstruction.
Okay, does anyone have any last few questions? Okay, I think that's the last of the questions. We just have a few more slides to put up, if you bear with us a second. So we would encourage anyone who is interested in the subjects discussed today to please consider joining ANSTER. It's open to all fellows and members of Fransker. It's free, it's fun, you'll get regular newsletter updates, and it is a very effective way to keep up to date with all things NLCSP. We have some upcoming NLCSP workshops on the Fransker NLCSP webpage. You will find links to the previous workshop webinar recordings and the next NLCSP workshops for Perth and Melbourne. These will be on a first come, first served basis. So if you can follow the link on here or log on to the Fransker NLCSP webpage, the registration forms are up there. We have a few pictures here of our previous workshops. This one was run in the Royal Brisbane Women's Hospital in 29th and 30th of March. It was very successful. Feedback was very good. We also had another one in Sydney at the start of April in the Phillips office in Northright. Again, really positive feedback from everyone attended. So we'd really encourage everyone, if you haven't signed up, to sign up to Perth and Melbourne. There are still spaces available. And finally, CPD, the really important part. For Ransker members, CPD points for attending this webinar will be uploaded to your individual CPD profiles by the Ransker CPD team over the next few weeks. You do not need to do anything to claim CPD points. For non-Ransker members, a certificate will be distributed to each member as proof of attendance to webinars. Certificates will also be distributed over the next few weeks. We are also going to distribute a survey, and it will be emailed out to all participants who consented in the registration form, and we would really appreciate it if you could give your feedback about the webinars. It really is important, and it will help us going forward. We will also be organising a 6th webinar in the series specifically about the structured clinical radiology report once it is published. We will send all the attendees of these webinars another registration link once we have a date and time confirmed, so please just watch the space. We'd really like to thank our presenters for taking time to be part of tonight, and we would also like to thank you all for attending. The webinar recordings will be uploaded to the NLCSP webpage on the Ransker website. We also want to let you know that have a good evening, and we hope to see you all at the workshops and maybe at the next webinar. So thank you very much.